And also thanks the Oncocritical Care Society for doing wonderful CMEs and programs. And I'm sure many of you would have been following the enhanced recovery after surgery, which is one of the accepted norms. At some places, it is part of the protocolized care, but other places, it will be the component that are being used for management of patients who are coming for uh, the cancer surgical procedures. So I'll take you through some of the important aspects, being a big session, and now we have ERAS protocols, which is even the procedure specific. So I'll take you through of majority of aspects. Now, when we talk about the conventional things, the traditional approach, how it all begins with, there were certain norms because in earlier days we didn't have a good amount of research. So based on the individual experience, people were following the traditional approach. Surgery was planned as soon as possible. The surgery, especially the cancer surgery, was considered as an emergency procedure, though it is labeled as time-sensitive surgeries, and people were taking about. And then from the cardiology point of view, where the concept of conditioning and the optimization emerged, was also put into the surgical patients, and how this is how people have started preconditioning, and this is how there was some possibility of prehabilitation which emerged on. And same traditional norms were there for post-operative. We remember those 4-to-1 formulas or third space losses and replacement. So there were many such things which were being used conventionally, though we didn't have a robust evidence for it, but people were comfortable. The cancer surgical procedures, whatever we do, whether it is from the anesthetic management or from the surgical management, now we understand that they have potential implication on patient outcomes. Now the patient outcome has changed in cancer surgical procedures. They are not the time of extubation or the analgesia, but they have emerged something as the quality of life, the return to intended oncology treatment, coming back to the receiving of the therapy as early as possible. So that's why we were thinking of how can these patients not only be extubated faster, shifted out of ICU faster, discharged from the hospital faster, but also can we start their therapy, which are they supposed to do, which may be the radiation therapy or the chemotherapy, at the earliest possible. And at the earliest possible, there are definitely time frames, which usually say 4 to 6 weeks. So this means it is just not preoperative optimization, but our perioperative care should be in such a way that the post-operatively, they should return back to the normal optimized status so that they can receive the treatment. And that is what we were thinking of in the RAS protocols, which is basically to enhance recovery and also to prevent complications, because any complications, if these patients suffer in the perioperative care, obviously they will delay the recovery, and that further will delay the treatment they would have received on time. And that's why various researches came up, and there are definitely many advantages we have now belief, even including the cancer surgical procedures, and hence it has become more of a protocol. And this has more implications into the cancer surgical procedures, because we know it is a complex procedure, long duration, extensive resections, inclusion of flaps, reconstructions, etc., and etc., in addition to the psychological impact. So this has impact on the overall outcome, and hence it has been seen that if you follow certain perioperative steps or components of IRAS protocol, probably the outcome becomes good. And that's why we are moving from the individual specialized care in the form of surgical oncology or just anesthesiologist or onco-anesthesiologist. We are looking for the team approach, and that's why all those things comes when we talk about the cancer care. And in view of this, not only in the non-oncology, but in the oncology, though it was to begin with GI surgical procedures, but now IRAS protocols are emerging more and more into the practice for majority other procedures also, and as lately as even the head and neck surgical procedures have their own IRAS protocols. Now there are certain steps that is found to be beneficial when we talk about the cancer surgical procedures. They start before surgery, continue during surgery, and they are extended after surgeries also. And when we talk of oncological procedures, even the long-term outcomes also needs to be included into IRAS protocols. So not right now, but it is perceived that it is just not say 48 hours or 7 days, but the long-term follow-up should also be a part of somewhere in the IRAS protocol. The reason clear that they may come up for repeat surgeries, or they may be landing up into a critical care setup where the continuum of care needs to be provided to these patients. And that's why the care starts. Though being an onco-critical care society, but as I mentioned, that when we talk about oncology, we have to work in team, and probably the team needs to understand what other team members are doing it. So the inclusion of pre-admission information, education, counseling, so that their compliance to the various parameters becomes good is very important. Similarly, we know that the albumin is an independent marker of the outcome of these patients. Cancer patients, because of many reasons, they do have many issues, and that's why the preoperative nutritional care needs to be there for these patients. Cancer patients are, because of many reasons, smoking is one, and it do have a limited effect. So we have to take care about these dependency and the organ involvement also. And as I mentioned, that nutrition is a big issue. We need to take care of the anemia management, which can be multimodal, because these patients may have nutritional issues because of on one aspect, it may be a hypermetabolic or a cachexic phase. On the other aspect, there may be a effect of the chemotherapy. On the third aspect, it may be because of a decreased intake. And hence, we have to include all those things. And these all are summarizes, or they are in the package format, which we labeled as prehabilitations. Depending upon the individualized care, the components of prehabilitation probably would differ for each patient. For example, thoracic RAS protocols will have something little different as compared to the RAS protocols for GI surgical procedures. Simultaneously, these patients may have the comorbidities. What we can do is to optimize them. We cannot cure them. If somebody is a diabetic, hypertensive, we cannot. But if somebody is anemic, we can. So we need to optimize or stabilize these aspects in the preoperative period, because they have been found to affect the quality of life and the ROID that we have discussed earlier. Now this is interesting, and people are now following in India also, and there are a good number of research from India also, and we have the Indian Society of Anesthesiologists also have released the preoperative fasting and postoperative feeding guidelines for the first time in the world at least, and they talk about that we do not need a prolonged fasting for these patients. And that's why we should be carefully taking care of the timings where they can be fed in the preoperative period, and simultaneously to have a good recovery so that we can feed them at the earliest in the postoperative period also. And that's why these guidelines, feeding and fasting guidelines, are getting popular. And the important aspect is, which I just need to your knowledge is, when we talk about the preoperative fasting, we have been running behind the traditional Western fruits, which was like coffee without milk. But it is difficult to understand that how many of us will drink a coffee without a milk. I think maybe some elite class, but not everybody. What we need to understand is we have many other things which we usually take, like coconut water, rasam, as well. People are very fond of ruh-afza and sharbats. So these are the things that also needs to be considered rather than thinking of without milk coffee or appies or maybe the commercial products which are costly. Why not to include these simple things which are equally acceptable? And when we are doing research on this, we found that their constituents are almost similar. So why not to use dal water rather than looking for a coffee, which many of us may not like. The bowel preparation is other aspects. I think now most of us are well versed with. Does not be to be done in all patients. Very exceptional selected patients require bowel preparation. Similarly, is antibiotic prophylaxis. Usually in oncosurgical procedures, major surgical procedures, they are started, but time should be appropriate. And these are usually based on the organ specific as well as the institutional protocol. The important aspect is, like in the previous old time, we were very fond of using povidone iodine as the scrub solution, but we are moving away from it, and chlorhexidine alcohol is the accepted norms and is being used at many places. But if not available, the second choice remains, but if available, we need to be more favorable to chlorhexidine solution for our interventions also. Now this is the nutshell. I may not be going into detail that when we say enhanced recovery, the less is more. It doesn't mean that we are giving less care to these patients. What I mean is less use of the agents which can prolong the recovery. So less use of those agents is preferred, and that's why we are moving towards using short-acting agents, drugs at minimum doses with appropriate. And that's why days are gone when our PAC needs to be standard tablet diazepam 10 milligram HS in morning or midazolam 7.5 HS in morning. I think those have been avoided now because we know it delays the recovery, it increases delirium, and it has many implications. That's why we need to avoid it. And similarly, there have been many aspects where routine dosages of the preoperative therapies of various agents which were given to these patients needs to be avoided because we have better agents now, better modalities, and that's why we should be careful. Inhalation anesthetics, yes, we have the options of using newer agents which have faster recovery, and we need to prefer it. Similarly, the neuromuscular blockade, we should be using it under monitored conditions so that we can extubate them at the earliest, and the options are available. And more recently, with the availability of Sugamadex, I think that's is available in India also, and probably the availability of remifentanil very soon in India will change the scenario that these patients will be recovering faster with good analgesia. And for the management of analgesia, we have to use them judiciously. In the earlier days, we had very few options, maybe the central neuraxial blockade plus intravenous analgesics, but now there are many options with us. What we need to do is we need to understand the pain of these patients, and that's why when we say education needs to be given to these patients. These patients should also have something called acute pain services in perioperative. So those analgesic gaps, the SOS dosages needs to be avoided, and same needs to be done in the post-operative period, even if they are shifted to the critical care unit, that these patients should have sustained analgesic, and we have various options for them. And when we say multimodal therapies, now we have a good armamentarium of blocks in the form of regional techniques. We can use shorter acting opiates, even including and empowering the patients, so-called as patient-controlled analgesia, and we can add on the non-opiates and adjuvants to this. Opiates has its own implication. We want better recovery, early recovery, and that's why the combination of this multimodal analgesia with the use of non-opiates, adjuvants, along with the various new blocks, including the various facial plane blocks, can be used for these patients. And what is emerging as a good step nowadays for last couple of years, though many of the drugs in anesthesia is coming back, like for example ketamine, and same thing has come back as intrathecal morphine, which is now being included into procedure-specific management also, and it is giving or reducing the dose requirement of many other agents with good recovery. Hypothermia, the perioperative hypothermia is very, very crucial for these patients because extensive surgeries, major blood loss, major fluid shift, and hence we have to be cautious because it affects multiple systems. The cardiovascular, the neurological, the coagulopathies, and all these will lead to increased morbidity and maybe sometimes mortality also. And hence, we need to prevent hypothermia happening. And similarly, after major surgical procedures, when these patients are shifted to the critical care unit, we have to be very cautious that whatever the damage or insult has happened during the intraoperative period needs to be reverted back to the normal values. Similarly, the PO&B prophylaxis, which is common for these patients, as these patients, cancer itself is one of the risk factors. Similarly, these patients may be on drugs like chemotherapeutic agents, and hence these patients have increased chances of PO&B, and that is what we need to use various techniques, the multimodal approaches, decrease usage of opiates, more use of regional blocks, reducing the fasting duration, starting them on early post-operative feeding for these patients, maintaining good analgesia, multimodal techniques. I think these are the package that we can provide to these patients to prevent nausea, vomiting. And hence, we need to use sometimes combination of drugs also. We can always combine depending upon the risk factors these patients have. Now, this is another important aspect of IRAS protocol, the fluid therapy. Now, this is important because the earlier strategies, though they are long back, where we talk about the tubular systems or the compartment syndrome, compartmental body structures for fluid has been converted into a glycocalyx model. And we understand that it's not tubules which are devoid of water. They are much more complex than we do understand them. And that's why third spacing has become a myth. So there's nothing called third space now because glycocalyx model has given absolutely a new way. And that is what we are talking about, the goal-directed fluid therapy for these patients. In major cancer surgical procedures, especially if we talk about GI surgical procedures or lung surgeries, we have to think of how much fluid is enough for these patients. Everything need not to be replaced intraoperatively. Sometimes we have to replace them in a sufficient way, in a controlled way, and that's why the optimal use of vasopressors has emerged. We also need to understand the anesthetic technique that we undergo, that we give to our patients, also have physiological aspects. So these patients are actually not under volemic or having loss of fluid because of the vasodilatation or cardiac depression, which will go away because we are using shorter acting agents now. So the vasopressors intraoperatively is a good option, and we have good research for this. So this means the perioperative fluid management needs to be in the perioperative period from pre, intra, and post-op, and that's why even in the ICU, we have to take care of them. The post-operative care is important. We need to provide them good analgesia so that they can be mobilized further. The various catheters needs to be removed at the earlier as part of ERAS protocols. The urinary drainage, urine output is one of the indicator, but we need to remove it as early as possible so that not only the infection rate, but we are following as one of the component of ERAS protocol. Same with nasogastric tube. If we start them early feeding with good pain relief, early ambulation, we can also remove NGs faster. Thromboembolic prophylaxis, these are high-risk patients, and hence we have to have a multimodal approach if indicated prophylactic pharmacological agents, but definitely the other compression devices or stockings and early ambulation is important for these patients. The previous session, Dr. Yash Javeri has already talked in detail about the ICU admissions. The routine ICU admission is not mandatory for all these patients. Depending upon individualized patient care or depending upon the high dependency unit facility that we have, we can think of the ICU admissions. Having said that, whatever we do, because each institution will have different protocol, each institution will have different infrastructure or different care pattern, we need to audit and try to improve upon the pattern of the various complications or delay which is happening, and then we can always try to improvise on the existing stepwise protocols so that we give maximum benefit of various components to our patients. So to summarize, when we talk about the ERAS protocols, yes, there are many. It has to be patient-centric. There's nothing called fixed protocols, which gives us guidelines. The patient involvement is important, patient-centric is important, and multidisciplinary approach is equally important for these patients. And once we try doing so, we will be able to manage many of the issues which probably were seen in earlier days, but they are in a reducing incidence now because we understand better, we empower better, and we intervene better because ERAS protocols has make us more wiser. So the ERAS pathways carry clinical and economic values. These are effective way of providing improved surgical care in the cancer patients. And we need to work as a team from pre-operative to the post-operative, including critical care unit, so that we can improve the perioperative outcomes, which is just not the length of hospital stay or ICU stay. They are much more than that, which is now earlier ROAT, and now we have gone a step further. Now this is the quality of life of these patients. So thank you so much for patient listening and comments or feedbacks.
Thank you, Dr. Rakesh, for such an enlightening and informative presentation on ERAS.
Thank you, madam.
I have a small query for you. See, ERAS is being followed a lot nowadays, but from an oncosurgery point perspective, these surgeries are time sensitive, like you've already informed us. But ERAS protocol involves preoperative optimization, prehabilitation, cessation of smoking for 4 weeks, you tell them. But tell me, would you wait for 4 weeks before a CA esophagus surgery just to optimize the patient?
Right. So I think this is an important question. So one side we say they should be done as early as possible, and we say time-sensitive surgery, which is 4 to 6 weeks. Now, what we need to understand is we are saying optimization. We are not saying that there needs to be cured or completely brought to the normal baseline values. So what we need to do is the teamwork that we have, the moment they are registered with the surgical oncology, like for example, say I'm looking for CRS, HIPEC, and the thoracic cases nowadays. So moment they are registered under surgical oncology, same day they are referred to me. And we both are syncing in the same way. So probably now even they have made a stamp which they put on the OPD for prehabilitation so that the patient understands those things much better. So I think we have to be in sync and take advantage of that 2 to 4 weeks when these patients are being assessed for many aspects. And this is usual waiting period for these patients, maybe 2 weeks, 3 weeks. So that 2 to 3 weeks should be very judiciously used for prehabilitation rather than when they are planned for surgeries and we have a OT list and then we start thinking of
We
rehabilitation.
don't delay the surgery, but we utilize the time available optimally.
Yes, absolutely.
So one more thing, amongst for post-operative nausea, vomiting, we have multimodal drug therapy instead of say just using maybe ondansetron or maybe. Okay, so what's your take on dexamethasone on that? Because dexamethasone, like we know, we don't give it in diabetics; it is diabetogenic, but then it also causes immunosuppression, cancer progression. So should we use dexamethasone in cancer patients for PONV?
So I've been using dexamethasone very routinely for majority of my
NNT is as
patients.
good as ondansetron.
Absolutely.
NNT is 6 for both the drugs.
Absolutely.
It's better than perinorm.
Agreed. So when we say the high-risk surgical procedures, so there are certain high-risk surgical procedures, like for example, female, young patient, GI surgical procedures, high-tech procedures, probably they are intubated, so not a big issue, or they have received preoperative chemotherapy. On those, preferably start using 2 agents. And to add on, if you see the recent literature, the use of aprepitant is emerging a lot. So they are longer acting agents and you just give them a single shot and they have a huge effect. So recently, I think the issue which is coming, I say just a week later, so I'm just pre-releasing it. There's a good meta-analysis in which they have found that the use of aprepitant is better as compared to combination of ondansetron and dexamethasone as compared to alone dexamethasone and the ondansetron. So this is a meta-analysis, good number of studies into this. So just wait for a week, you will see on the groups how this meta-analysis is. So this means this is proving that we have to immerse with the newer drugs, safer drugs, and we should be careful because PNV is one of the important parameter that delays recovery. And especially somebody who's going thoracic or GI surgeries, it will delay. So why not to use combination? Second, you said about steroids. So there is sufficient evidence now that single shot of dexamethasone in 4 or 8 milligram is not going to change the diabetic status of a patient. They are not immunosuppressants and they are not contraindicated into the oncosurgical procedures. But I'm talking about single dose. I think that's sufficient because most hematogenic effect of the perioperative period is within 24 hours and dexamethasone works for 12 hours. So I think single dose, no contraindication. Sufficient research now.
One question that
Yes, sir.
in thromboprophylaxis you told that it is till 4th week in the post-operative period. But sir, in many cases, in the later stage also reported cases. So thromboprophylaxis, there are some changes in the guidelines or still in the 4 weeks?
No, so yeah, so there are 3 categories of patient population here. One is who are not at high risk, neither the surgery nor the patient. So they are usually given for 3 to 5 days and stopped. Certain patients will require 4 weeks. Certain patients population will require for longer durations, like for example, CCA ovary cytodeductive surgeries. So they may have it. So it is an individualized care beyond 4 weeks. But for that duration, it needs to be given to majority of patients. And now with the emergence of oral drugs, the things has become easier. A couple of years back, it was low molecular heparin basically, or people used to use aspirin, but that was not having any role as such. But now being the oral drugs, they may be given to some of these patients depending upon the presentation they have or the symptoms they have.
Still very costly, the DOX.
I know, I agree. Yes, sir. Yes, sir. You can give a feedback also. You are an expert in this group, sir. Absolutely, sir. So when we talk about monitoring, use of the NMTs, that is the neuromuscular monitor, use of entropy or BIS, because we want not to give more drugs, but simultaneously we should not be giving less drugs also because psychological impact is too great. And sometimes we talk irrelevant in the OT also, especially in panic situation. So they are listened by the patient. Having said that, the entropy and BIS is an important parameter because when the BIS was introduced a couple of years back, we used to say that it should be kept somewhere 30 to 40. But now what has recent changes, 30 to 40 is not for all patients. Even 60 is acceptable for certain patients because we are using now multimodal technique, the regional techniques of pain management. So we do not need 40 to suppress the brain to achieve all the benefits. The multimodal strategies is taking it higher. So if you want to take it 60, then we have to measure it, and that's why you rightly said BIS should be the important, especially for high surgical procedures, and should be used wherever possible.
I'd like to add something to that, because the IRAS Society guidelines on anesthesia protocols, they say that you can either use BIS or you can use a MAC value of end-tidal MAC value of 0.7 to 1.3. So they've conducted a study which has equated MAC values of 0.7 to 1.3 to give the same result as a BIS value of 40 to 60. So if you don't have a BIS, you can use this end-tidal MAC of 0.7 to 1.3.
So the difference between what Dr. Shagun is, it's not the MAC value because that will be affected by many parameters. It's the end-tidal values, which is very, very, I mean, this is almost equivalent to BIS nowadays, and newer monitors, newer LCA workstation do have it. Thank you. I'm done. Yes, sir.
You see, we are listening to pre-habilitation in almost every conference. But when it comes down to implementing more so in the private sector, if I tell the patient we will undertake your surgery after 3 weeks or 4 weeks, once you are optimized, the patient normally jumps from this institution and gets the surgery done elsewhere. That is one. The other practical aspect is we have quite a large number of patients who are not staying in Delhi. So if to optimize the patient is to stay in Delhi and get his pulmonary functions and nutrition optimized, a patient who has come from Nepal, you are adding costs. So these are some of the deterrents I do not know. You must think over it, how to find a solution. Because large number of patients of prehabilitation are not adequately optimized, number one, because probably our surgical colleagues are not too very convinced. And number two, because of these problems which the patient faces of staying over when he comes for surgery.
Sir, absolutely right, especially like yours is a tertiary care center like ours. So it is definitely an issue because these patients will be worked up partially at different small hospitals, and then they will be coming to a tertiary care center, especially for major surgeries. So we recently did a study as a part of a DM protocol for the head and neck surgical procedures. So what we need to do is the first, the IRAS, patient education. I think that's the most important. So we just prepared a small booklet, which is soft copy and hard copy, and the patient, whenever they comes for the first time, at least give them something. So it has certain components. That's why I say that IRAS has many components to it, sometimes crossing 25. We may not be able to implement everything. And if you see many studies, the compliance of the IRAS protocols is ranging from 60 to 80%. I hardly see a study where the compliance is 100%. So whatever they can do is out of our benefit. Say, for example, if you just ask them to walk for a kilometer, start from 500 meters and do it daily, or give a deep breathing exercises, or start an incentive spirometry, or start a high protein diet, I think this component will add on to some certain things. And when they come to us, maybe for 2-3 days, we can add on to it rather than starting from something new. But I fully agree that I think, sir, you as one of the leader, I can request you that why not to have some platform where we can say it is for patient education open for everybody. And we can say if somebody is coming for thoracic surgeries, cancer surgeries, this is the platform of our open platform and you can start them. And it should be, in some way videographically, like we are doing for CPR programs and we are doing for, sir is doing for end-of-life programs. I think same thing, we can create more awareness among the public so that whether they come to your hospital or my hospital, I think leaving apart the economic concerns, but we can always help the patients across the hospital. Looking forward for a website from you, sir.
Thank you. जो बोले वो बुआ खोले.
No, sir, I know you well, sir. You have been my teacher, so I know you well. You can do anything and everything, sir. That's why I requested. Thank you so much. Thank you.